Okay, good morning all. Today our topic is about anorectal malformation. So just wait a minute. Yeah, it's working, right? Yeah. Today we will see about anorectal malformation. So we'll go into the topic straight away. So coming to introduction. So what are anorectal malformation? This is a complex group of congenital anomalies involving the distal anus and the rectum as well as urinary tract and genital tract. So it is more common in babies. Though the prevalence is approximately 5,000 per live births, with male babies are slightly more commonly affected. In most ARM means anorectal malformation. So in most ARMs, the anus is not perforated and the distal entry component means the bowel component, that is the rectum, may end blindly. Blindly means it's called atresia. There is no opening or the mucosa is atropic or as fistula into the urinary tract or genital tract or in perineum. ARMs are associated with other congenital anomalies associated with up to 70% of the patients. The final prognosis and quality of life will depend on the presence and gravity of the associated anomalies. So the introduction sums up is, so it is most commonly slightly predominant in the male babies and associated congenital anomalies will be present. So that will decide the prognosis of the baby. So before moving into the proper topic, we need to know the embryology of the rectum, anal canal and the genital tract. So we'll have a brief embryology. Okay. So how the rectum, that is anal canal and the rectum develops. So the caudal end of the hindgut. So hindgut is basically the rectum and the anal canal. So dilates to form a cloaca. The cloaca is connected to the allantois ventrally and it is closed caudally by the cloacal membrane. So the mesoderm at the angle between the allantois and the hindgut proliferates and invaginates the endoderm of the cloaca, forming a septum called urorectal septum. So the septum extends caudally to divide the cloaca into a primitive urogenital sinus ventrally and anorectal canal dorsally. So further extension of the urorectal spectrum caudally divides the cloacal membrane into two parts. That is, anterior part is called urogenital membrane and the posterior part is called anal membrane. So this sums up the embryology of the anal canal and the urinary tract. So you can see clearly that there is a cloacal membrane, the urogenital septum and the rectal septum. Between that, cloacal is there. So it's called hindgut. And there is a primitive urogenital sinus through which the genital parts and the urinary tract develops. So this is the embryology you need to know. So the upper part of the anal canal is called endodermal origin, being derived from the endoderm of the hindgut, and it is supplied by superior rectal artery, which is the continuation of the inferior mesenteric artery. The lower part of the anal canal, that is ectodermal in origin, being derived from the proctodeum, it is supplied by the inferior rectal arteries, which are branches of internal pudendal arteries. So the line of fusion of the endodermal and the ectodermal parts of the anal canal is marked by a line called pectinate line that lies below the anal column. So this line marks the transition of the anal canal lining from simple columnar to stratified columnar epithelium. So ectoderm between the previous membrane to form the perineal body. So further proliferation of the mesenchyme around the anal membrane creates an ectodermal depression around it called proctodome. So another anorectal canal forms the mucosa of the rectum and upper part of the anal canal. So the lower part of the anal canal is formed from proctodome. The anal membrane ruptures at the 7th week of development of a baby so that the two parts of the anal canal becomes continuous together. The mesenchyme surrounding the anorectal canal so forms the musculature of the rectum and the anal canal. So coming to this, this sums up the embryology. So coming to the classification of anorectal malformation. So it is basically there are three classification. The most commonly accepted is wing spread classification. And you also want to know what is Krickenberg classification and the anatomical classification. So wing spread classification is divided into high, intermediate, and low. So it is separately there is something piled up for boys and girls. So in high malformation, that is prognosis is very poor. So in boys, the anorectal agenesis will be with rectovesical fistula, with rectovesicular fistula, without fistula, and rectal atresia. Contrary to the girls, in the anorectal agenesis is with rectovaginal fistula, without fistula, and rectal atresia. So coming to intermediate, that is rectobulbar. Bulbar means bulbar part of the urethra. So rectobulbar urethral fistula, anal agenesis without fistula. And contrary to girls is vestibular fistula, rectovaginal fistula, and anal agenesis without fistula. Coming to low, low is anocutaneous fistula, anal stenosis, and in contrary to girls is anovestibular fistula, anocutaneous fistula, and anal stenosis. So in this wing spread of classification, high, that is anorectal agenesis, both boys and girls is carries a poor prognosis. These babies will not do well even after surgery, but comparatively low, that is the lesions that are low, that is anocutaneous fistulas, anal stenosis, these babies will do well after we do surgery. So that is wing spread classification. Coming to Krickenberg's classification, this is very simple. So he divided Krickenberg divided into only major clinical two groups, major clinical and regional variant. That is perineal, cutaneous fistulas, rectourethral fistula, prostatic and bulbar. That is rectourethral, rectovesical, vestibular fistula, cloaca. There is no fistula, only stenosis, anal stenosis. Coming to rare or regional varieties, that is pouch colon, rectal atresia stenosis, rectovaginal fistula, or H shape of fistula, and others. So this is very easy, but wing spread is the accepted one. But you should also know what is Krickenberg classification. So coming to anatomical classification. So anatomical classification, anatomical type, that is depends upon male and female. So perineal fistula is common both in male and female babies. Coming to rectourethral fistula, that is bulbar or prostatic fistula, but here only rectovestibular fistula, one type is there. Second one is rectovesical fistula, that is bladder neck. Here, persistent cloaca, that is less than 3 centimeter of the common channel or more than 3 centimeter of the common. Here, the common channel indicates that both rectum and the urethral combine. That is, there is a connection between the rectum and the urethra. That is called, that pathway is called common channel. So that is less than 3 centimeter or more than 3 centimeter. So in boys, that is male. Male, it is imperforate anus without fistula. In females, imperforate anus without fistula. Both the things are then rectal asphyxia. So these are the three classifications you need to know. That is wing spread classification, Krickenberg classification, and anatomical classification. Most accepted is the wing spread. That is male, female, anorectal, high, intermediate, and low. High is very poor prognosis. Low is very good prognosis. So this is a crunch of this classification. So coming to the anorectal malformations in boys. So there is rectoperineal fistula. Rectum is not opening into the opening properly. It is opening in the perineal area. Rectum is located within most of the sphincter mechanisms. Only the lower part of the rectum is anteriorly mislocated. So sometimes fistula does not open into the perineum, follows a subepithelial midline tract along the perineal raphe, scrotum, and base of the penis. So that is rectoperineal. So the rectum will open. The sphincter mechanism will be good in these patients, but the rectum will be open in the midline along the perineal raphe, scrotum, or base of the penis. And the rectourethral fistulas, that is imperforate anus with rectourethral fistula. Most commonly, this is the defect. This type of defect is seen in boys. There are types of recto, that is rectobulbar and rectoprostatic. Above the fistula, rectum, urethra share a common wall. Lower the fistula, longer the common wall. That is as I discussed earlier. Rectum usually distended. It is surrounded by a levator muscles. Between the rectum and the perineal skin, striated muscle complex is present. So lower urethral are usually associated with good quality of the muscles. So because the sacrum is well developed and there will be a prominent anal dimple. So these are the types of rectourethral fistula. You can see there is a rectoperineal fistula and there is rectourethral fistula also. Rectobladder, neck of the fistula. Rectum opens into the bladder of the neck and carries a poor prognosis for bowel control because the muscle complex and the sacrum and the anal dimple will not be poorly developed. This is constitutes in 10% of the male babies. And imperforate anus without fistula. So rectum terminates approximately 2 centimeters from the perineal skin. So rectum and urethra do not communicate, and these two separated with a thin common wall. About half of the patient with no fistula have Down syndrome, and more than 90% of the Down syndrome will have this defect. So Down syndrome in 90% will have this defect. That's what I'm trying to convey you. Coming to rectal atresia, it is an unusual defect. Lumen of the rectum is totally atretic or partially stenosed. So upper pouch is represented by a dilated rectum and lower portion is represented by a small anal canal in the normal location. These two structures are separated by a thin membrane or dense fibrous tissue. So we have finished the types of ARMs in males. So moving on to female anorectal malformation anomalies in females. Vestibular fistulas. Most commonly a defect in girls and has excellent prognosis. Inspection of the external genitalia shows a normal urethral meatus, normal vagina, and the third hole is the vestibule. So this has a good prognosis. And coming to persistent cloaca, this defect should be suspected in a female born with undeveloped rather to say underdeveloped external genitalia. Defect in which the rectum, vagina, urinary fuse together, creating a common channel. So this is the very carries a poor prognosis in a female child. So two types that is I told earlier: long channel more than 3 centimeter and short channel more less than 3 centimeter. So in the second picture you can see three channels constituting this. So this is less than 3 centimeter. So this is very difficult to treat persistent cloaca. So moving on to the associated defects, as I told earlier, mostly 70 in the introduction part, 70% of the babies will have associated. This associated defect will decide the prognosis of the baby, survival of the baby. So coming to sacrum and spine, most commonly associated defect is more than two absent sacral vertebra carries a poor prognosis in terms of poor bowel control and urinary control. Sacral ratio allows more objective evaluation of the sacrum. Normal sacral ratio is 0.77. So sacral ratio less than 0.3 will develop a poor bowel control. So this constitutes the bone, that is sacrum and spine defect. So coming to genitourinary defect, 20 to 50% of ARM is associated with this defect. Higher the malformation associated with defect, rectobladder neck and persistent cloaca. So children with low ARM have less than 10% of associated with the associated defect. Thorough urological evaluation to be done in high ARM. So this is a picture showing the for the taking the sacral ratio, that is iliac crest A and B, tip of the sacrum, posterior and inferior iliac crest. So A divided by B, that is called sacral ratio. It should not be less than 0.3. If it is less than 0.3, the sacrum is underdeveloped. The baby will not have a good sphincter mechanism or muscle mechanism to hold the rectum. So generally we should look for vectoral association. That is examination of, you should examine the spine, passage of nasogastric tube, central cyanosis. You have to look for limb anomalies and examination of the genitalia. Examination of the perineum. So presence or absence of anus. You should look for gas or meconium from perineum. Presence of vaginal and urethral opening. Size of the vaginal introitious, size of the anal dimple, and position of the anus. So these are the things as a pediatrician or as a general surgeon you should look for if a suspected case of anorectal malformation. Midline groove, anal membrane, and the presence of presacral mass and number of opening in the vestibule. So coming to what are the imaging studies we can do to confirm or to evaluate what type of defect is baby is having. So first thing is invertogram, cross table lateral radiography, USG abdomen and pelvis to rule out genitourinary anomalies, ultrasonography, that is transperineal infracoccygeal ultrasonography, maturing cystourethropy, intravenous pyelography, and CT scan, MRI, high pressure distal cholecystography. So these are the number of investigations, but in this most important is invertogram, cross table lateral radiography, ultrasound abdomen, CT scan, and MRI. So coming to invertogram, so in invertogram we should look for three line, that is pubococcygeal line, the ischial line or eye point line, and the anal pit line. So a gas bubble situated above the PC line, that is pubococcygeal line, is designated high anomaly. One located between the pubococcygeal and the eye line ischial line or point intermediate anomaly. If it extends below the eye line or point line, then it is called low anomaly. So you can see it is a low ARM. So the gas bubble is below the ischial line. So in his, you can see gas bubble is above the eye line, that is, sorry, pubococcygeal line. So it is high MRM. This carries a poor prognosis. Coming to cross table lateral X-ray, the prone cross table lateral X-ray should be delayed for 12 to 24 hours after birth. So this allow the gas to reach the distal rectum. The baby should be placed in the genupectoral position for 3 minutes before taking the film to allow gas to displace meconium and the rise of the termination of the pouch. Barium paste or contrast soaked gauze placed in the natal cleft. It is more accurate than a metal marker. So a catheter may be placed in the urethra to make delineation of the urethra more obvious. Although this is not essential, we can do to delineate the urethra. So the greater trochanter should be marked with a marker pen on the upper thigh, and the X-ray beam is centered on this spot. So coming to ultrasonic examination. Ultrasonographic examination has been used to know the pouch and the perineal distance. It can be performed through a transperineal or infracoccygeal route. So in infracoccygeal route can be directly demonstrate the puborectalis as a hypoechoic U-shaped band. So the non-invasive nature and no radiation exposure are the main advantages, but it is highly observer dependent. In ultrasonic exam, it's very difficult to rule out the ARM. Coming to CT and MRI. So CT and MRI of the pelvis have been utilized for the direct visualization of the sphincteric muscles. So whether the muscles and the sacrum associated anomalies also we can find out, that is sacral bone is missing or not. 2 to 3 sacral bone is missing. If it is missing, so the muscles of the sacrum is not on, the muscles of the sphincter mechanism is not developed well. So patient will have a poor prognosis. So this investigations has been used for structural evaluation of the pelvic floor muscles, as I said earlier, and relation to the pouch. So for both pre and post operative evaluation. The exact location of the fistula and relation to the pelvic floor muscle provides crucial information regarding the approach. Whether sagittal approach is needed, that is, we will discuss later in the upcoming slides, or an approach through the abdominal route is required. So, MRI and CT can be utilized for the assessment of structural development following different procedures of ARM. So, MRI is considered is superior to CT because the excellent soft tissue, because MRI have a excellent soft tissue characterization and multiplanar imaging and lack of ionizing radiation. These are advantages of MRI over CT in ARM. So, coming to high pressure distal cholecystography. This before the definitive repair of the ARM, distal cholecystography is performed in most of the valuable and accurate diagnostic study to define the anatomy of the anorectal malformation. So, how will you do is you will give a water soluble contrast medium is instilled into the distal stoma, which fills the distal intestines and enable the demonstration of the location of the blind rectum and the precise site of the recto-urinary fistula. The contrast medium must be injected with considerable hydrostatic pressure under fluoroscopic control. Then the use of a Foley catheter is recommended. It is passed through the distal stoma. So the balloon is inflated 2 to 5 ml and it is pulled back as far as possible to occlude the stoma during the injection of the contrast medium. This maneuver permits to overcome the muscle tone of the striated muscle mechanism to fill the rectum and demonstrate the urinary fistula when present. So these are the investigations we will follow if we suspect a patient, baby with the ARM. So coming to the management protocol. So if a newborn male baby with anorectal malformation, you are suspecting. So perineal inspection, first clinical evaluation, that is perineal inspection. If we are saying looking in directly, you are made a diagnosis as perineal fistula, go for anoplasty. Then evaluation. So you are not you are not sure enough to diagnose. So you are ordering for investigation. That is urine analysis, kidney ultrasound, sacrum, spinal ultrasound, esophageal atresia, and echocardiogram. All these investigations after 20 to 24 hours re-evaluation on cross-table lateral film. So rectal gas above the meconium in the urine, associated defect. So flat bottom, colostomy. Why we have to do colostomy? Because high anal high anal fistula. Then rectal gas below the coccyx after you doing cross table lateral venom, negative urine analysis and there is no any defects. Consider PSARP, that is posterior sagittal approach with or without colostomy. So this is the overall management protocol. We'll go in detail about the surgeries. So for girls, same thing. Newborn female anorectal malformation, perineal inspection. So evaluation after 20 to 24 hours. So these are the in your right hand side. These are urine analysis, kidney are same as male babies. You will do that. So after this, you are coming to a conclusion, that is, if it is a perineal fistula or vestibular fistula, go for anoplasty or dilatation of the colostomy, dilatation or colostomy. Single orifice cloaca, colostomy with hydrocolapse drainage if present. No fistula on cross table. Colostomy if gas above the coccyx, or anoplasty if the gas below the coccyx. So this is the overall management for girl babies. So treatment. How will you treat? Management is okay. Protocols are okay. So how will you treat? During the first 24 hours, patient should receive IV fluids, IV antibiotics, and nasogastric tube aspiration. Also, you should rule out other associated condition. So, coming to posterior sagittal anorectoplasty. When a low anomaly, that is perineal fistula, is diagnosed, which the anus is always located anterior to the sphincter mechanism. a limited posterior sagittal anorectoplasty can be done. In babies have significant associated anomalies, dilatation of the fistulous tract is appropriate with a plan of repair in the future. It is advantageous to perform this operation in the first 48 hours of life. For a limited posterior sagittal anorectoplasty, the baby is placed prone. In males, the urinary catheter is inserted. The distal end of the rectum is intimately attached to the posterior urethra. So, look at this. So, the distal end of the rectum is intimately attached to the posterior urethra, and the urethral injury should be avoided by placing the catheter. So, that is why placing a catheter is very important. So, multiple 60 silk sutures are placed at the mucocutaneous junction around the fistulous orifice. So, an incision divides the posterior sphincter in half and it is continued circumferentially around the fistula. So, while traction is maintained on the bowel, the circumferential dissection is performed to mobilize the bowel and reposition it within the limits of the external sphincter. Mucosa is sutured to the skin with fine absorbable sutures under slight tension and the perineal body is reconstructed. So, this is how we will do a posterior sagittal anorectoplasty. So, how will you do colostomy? The colostomy is usually performed as a first stage. If a baby is suspecting a high anomaly and a descending colostomy is relatively trouble-free of stoma, it is fashioned by making an oblique left lower quadrant incision. The edge of the wound, the proximal part of the stoma is placed at the start of the sigmoid colon. Stomas placed in mobile portion of the colon are prone to collapse. So the distal part of the stoma in the upper sigmoid is made intentionally small in an attempt to prevent prolapse. So the distal segment should be copiously irrigated to remove all the meconium. So a colostomy can result in insignificant morbidity. So it's vital to construct meticulously. Transverse colostomies is often lead to prolapse, so difficult to clean the distal segment. So and can result in perforation of the colonic segment while performing colostogram. So such colostomies also lead to megarectosigmoid and a left microcolon in the defunctionalized segment. So particularly when the colostomy is left in place for many months. So a colostomy that is placed too low in the sigmoid can limit pull-through maneuvers. A loop colostomy leads to distal contamination of the urinary system. So, if there is a fistula and it to be dilated, megarectosigmoid from stool spillage. So, later management after colostomy. So, before reconstruction, the anatomy of the anorectal malformation is delineated by high pressure distal colostography, as I discussed in the investigations. So, patient is required when performing, patience is required when performing loop graphy with a slow distension of the distal rectum so that the muscles of the pelvis are normally contracted and thus the distal rectum is compressed and cannot appear as a pubococcygeal flat at the pubococcygeal line. So with your gentle pressure, this flat line begins to bulge and it is at this point that the examiner can visualize the true extent of the rectum and the presence of a rectourinary fistula. So anorectal reconstruction basic principle. The patient is placed in prone position with the pelvis elevated. Special care must be taken to cushion all the pressure areas of the baby's body. So two small bolsters can be used in front each deltopectoral groove to avoid hyperextension of the neck and shoulders. A Foley's catheter is inserted into the bladder before the patient is positioned. So the catheter sometimes goes into the rectum through the fistula rather than into the bladder. So to avoid misplacement, a surgeon can directly catheter with a lacrimal probe inserted at the tip of the Foley to function as a guide. So a midline incision is created at the sphincteric mechanism is divided exactly in the midline with equal amount of muscle left on each side. So the rational for this approach is based on the fact that important nerves or vessels do not cross the midline. So the retractor should be placed superficially to avoid pressure damage to the nerves that run close to the wound. So posterior sagittal anorectoplasty for anomalies in male rectourethral fistula. Most common incision usually extends from the lower lower portion of the sacrum through the center of the anal dimple. So it is sometimes extended to the perineal body, particularly in boys with the rectum urethral bulbar fistula. So the levator muscle in the perineum is located deeper into the ischiorectal tract. So this muscle is also divided in the midline. In boys with the rectourethral bulbar fistula, the bowel is very evident and prominent and extends towards the lower part of the incision. So in boys with the rectoprostatic fistula, the rectum is much smaller and located much higher in this incision. So this is a valid point you should understand. So in boys with the rectal bulbar fistula, the bowel is very evident and prominent and extends towards the lower part of the incision. So this is the first thing. In rectoprostatic fistula, the rectum is much smaller and located much higher than the incision. This is the 2 points you should consider. Temporarily, the silk sutures are placed in the posterior rectal wall traction and the rectum is open exactly in the midline. So the multiple 6-0 sutures are placed above the fistula in a semicircular fashion. Once the rectum is fully separated from the urinary tract, the circumferential perirectal dissection is performed to gain enough rectal length and reach perineum. So the vessels that hold the rectum are coagulated and divided until enough rectal length has been achieved. So the urethral fistula is closed using interrupted absorbable sutures. And the perineal body is reconstructed, bringing together the anterior uh, limits of the external sphincter, the posterior edge of the complex must be sutures together in the midline. So anoplasty is performed by placing the rectum within the limits of the external sphincter with the use of the interrupted long-term absorbable sutures. So how will you manage rectum bladder neck fistula? The rectal bladder neck fistula is an abdominal approach via either laparoscopy or laparotomy. In addition to the posterior sagittal approach is necessary to mobilize the rectum. Imperforated anus without fistula is in this patient, the blind end of the rectum is located the same as the patient with bulbar urethral fistula. The repair is performed as a rectourethral fistula. For rectal atresia, the goal of the procedure is to connect the blind dilated end of the rectum proximally with the anal canal and proximally with the anal canal distally. So both the structures are usually separated by a few millimeters of the fibrous tissue. The rectum must be sufficiently mobilized to allow the performance of an end-to-end anastomosis of the anal canal. This is how we will treat the rectal atresia and stenosis. So that's end the surgical approaches for boys. So coming to the females. So patient with vestibular fistula are born with potential bowel control. So thus every effort should made give this patient the best opportunity to undergo successful reconstruction with a single operation. So with the patient in the prone position, a midline incision is performed, but it is not usually necessary to extend the incision as high as the middle portion of the sacrum, which continues around the fistula in the vestibule. Multiple 5-0 sutures are placed circumferentially at the fistula site. So while traction is performed on these sutures, this rectum is dissected in a circumferential manner. The posterior rectal wall can be easily identified and the dissection must start from the posterior aspect and extend laterally. So the separation of the rectum from the vagina is the most delicate part of the dissection. So the common wall between the rectum and the vagina in this kind of defect is long and extremely thin. So the limit of the spintric mechanism are electrically determined and marked with temporary silk suture. The perineal body is then reconstructed by bringing together the anterior limit of the external sphincter. So the anterior edge of the muscle complex is reapproximated as described previously. For males, the levator muscle is not usually exposed and thus does not need to be reconstructed. So the muscle complex must, however, be reconstructed posterior to the rectum by taking bites of the posterior rectal wall. The anoplasty and wound closure are performed as described for males. So persistent cloaca. So repair of this defect has three main goals: achievement of bowel control, achievement of urinary control, and sexual function. So a long mid-sagittal incision is made that extends from the middle portion of the sacrum through the external sphincter and down the single perineal opening. So the first consists of patients with a common channel shorter than 3 centimeter. Fortunately, this group represents majority of those cloacas. So the patient can usually be repaired via posterior PSARP, that is posterior sagittal approach alone without laparotomy. The second group consists of patients with longer channel. Longer channel means more than 3 centimeter. These patients usually will undergo laparotomy. So these are the surgeries for male and female babies. So what are the general principles you should follow in a post-operative care? In the absence of laparotomy, oral feeding may be begin in a matter of hours. Antibiotics are given only for 48 hours. In male babies who had a rectourethral fistula, the urinary catheter should be left in place for 7 days. And in case of female with cloaca, it is for kept for 3 weeks. So it's a point you should take home. That is, for male babies with rectourethral fistula, for only catheter you should place for 1 week. For cloacal repair in female babies, you should place it for 3 weeks. If a laparotomy was required for the repair, suprapubic cystostomy is created. A dilatation is begun 2 weeks after surgery, twice a day, and every week the size of the dilator is to be anal dilator to be increased by 1 unit until the desired size is reached. So once the correct size is reached, the colostomy is closed and dilatation must continue after closure also. So once the dilator can be inserted easily, the schedule is reduced to once a day for 1 month, once a week for 1 month, and then once a week for 3 months. So this is the protocol you should follow when once the colostomy is closed, the anal dilator uh, protocol. So a patient who has 1 to 3 bowel movements and show evidence of feeling of pushing during the bowel movements has a good bowel movement pattern and generally carries a good prognosis. Overall, higher the lesion carries a bad prognosis, lower the lesion carries a good prognosis. So thank you. We will meet in the next session. Hope you understand well. Thank you.